Hello, my name is Fiona Coath. I'm currently one of the rheumatology registrars in the East of England Deanery, but in a pre-tocilizumab world, I was the clinical research fellow at Southend Hospital, and Professor Descriptor has kindly asked me to briefly reminisce on our experience of getting tocilizumab approved for use in GCA in England back in 2018. So, if I can take you back to December 2017, for me personally as a clinician, the treatment of refractory GCA was very frustrating. There was obviously a group of patients who had relapsing course of disease despite steroids and despite some additional agents such as methotrexate and leflunomide. And as a research fellow, we were participating in therapeutics trials, some of which were cut short by the sponsors, leaving our patients without readily available options. Following the GCA trial, TCZ was now firmly on the list as a treatment option, but not yet available in the UK. And for those of you that have ever had to complete an IFR, the frustration when yet another request for tocilizumab in GCA was denied was palpable. By GCA, I am of course referring to this landmark trial, published in the New England Journal of Medicine in 2017, which was a placebo-controlled trial with 4 arms, 2 arms with either weekly or fortnightly tocilizumab with steroid taper, and the remaining arms with a steroid taper alone. The results were undeniable. Sustained remission at week 52 occurred in 56% of patients treated with tocilizumab weekly, and in 53% of those treated with tocilizumab fortnightly, as compared with 14% of those in the placebo group that underwent the 26 prednisone week taper, and 18% of those in the placebo group that underwent the 52-week prednisone taper. Moreover, the cumulative steroid dose in the tocilizumab groups was much lower. And this figure here is a graph showing patients without flare of GCA during the trial. And as you can see, patients in the tocilizumab groups, highlighted in purple and green at the top of the graph, were much less likely to have a flare. So, unfortunately, however, the NICE Appraisal Committee for England highlighted substantial concerns in the November-December 2017, with serious concerns that it would not be approved for use by clinicians. Further invitation for comment was requested, along with a closing date of the 4th of January, so not long. So many interested parties, including Professor and myself, got to drafting a response, including over the Christmas holidays. So initially, NICE quality or cost effectiveness calculations were performed on the GCA population as a whole, rather than taking into account the spectrum of disease and differing clinical paths of GCA patients. The traditional view of GCA as a glucocorticoid responsive disease isn't accurate. Observational cohort studies, as well as GCA, report relapses in 34 to 62% of patients, with only 15 to 20% of patients achieving long-term sustained remission with glucocorticoids alone. We believe patients should be separated into 4 subgroups according to treatment response, that being remission, relapse, refractory disease, and adverse effects or glucocorticoid intolerance. These last 3 groups exhibit the greatest unmet need for adjunctive therapy and should be considered for either DMARDs or biologics. Furthermore, these relapsing and refractory groups encounter large cumulative doses of steroids that can lead to serious complications with significant morbidity and mortality, and also a significant burden to the NHS if that was to be of interest to the NICE committee. This is compounded by the fact that GCA affects individuals over the age of 50, some of whom may have pre-existing health conditions which steroids would adversely affect. Additionally, we know that uncontrolled disease leads to further vascular complications from the disease itself. So finally, we received some positive news. Tocilizumab was approved by NICE, but under these strict conditions. It could be used only for patients with relapsing or refractory disease. They must have not already had tocilizumab, and tocilizumab should be stopped after 1 year of uninterrupted treatment. The reappraisal for this would be in 2 to 3 years' time following extension data. However, in the meantime, there have been a few high-profile world events which have influenced proceedings. Yes, COVID-19. So NICE issued an interim COVID-19 policy with the option to extend treatment beyond 12 months for certain high-risk groups, those being patients with large vessel or extracranial involvement, those who presented with critical ischemia, so visual symptoms, scalp necrosis or stroke, and patients with evidence of active disease between months 6 to 12 whilst on tocilizumab, but subsequently coming under control and therefore justifying its ongoing use. The concern being that relapse after 12 months could potentially expose these patients to an increased risk of COVID-19, either through hospital admission and or restarting high-dose glucocorticoids. We know up to 50% of patients will relapse within 2 years after discontinuation of tocilizumab. The extension data from GCA has now been released. And so the headline news is really a small proportion of individuals, about 10%, need only glucocorticoid treatment alone. And identification of these individuals should form part of an urgent research agenda. A further 15% can be put into long-term remission with tocilizumab for only 1 year. Others, however, will need long-term tocilizumab or indeed the hope of newer agents currently in the research arena. However, even in these latter patients, the steroid-sparing effect of tocilizumab is meaningful. And perhaps this will be seen even more so as the significant problems of glucocorticoids are due to the long-term metabolic changes. So ultimately, this first battle for tocilizumab and GCA was won, but the war is far from over. There is still lots of work to be done for refractory and relapsing GCA. Tocilizumab was definitely a positive step, as it's one of the first advances in treatment that we've had in many years. But it isn't a panacea, and research into other biochemical pathways and agents is required. The unmet need remains. Many thanks for listening.